Hello, everybody, and welcome to the webinar. We will begin shortly. And I want to welcome you to the webinar, The Science of Movement, Clear Aligner Biomechanics Explained. The lecture will be presented by Dr. Farah Majidalawi. And now I'd like to introduce to you our speaker, Dr. Farah Majidalawi. Dr. Majidalawi is a graduate of the University of Jordan. She has extensive experience as a dental practitioner, researcher, and volunteer. Now a clear aligner clinical education specialist, she advances treatment protocols, aligns clinical best practices, and integrates cutting-edge research and aligner technology to ensure optimal patient outcomes and innovative care. Dr. Majlawi, it is all yours.
Thank you very much, Nicole, for this introduction. Hello, everyone. I'm Dr. Farah, and today we're going to be going through the second lecture in this series of lectures on clear aligners with NDX. So today's topic will be the science of movement, clear aligner biomechanics explained. And before I begin, I just want to make a small disclosure. I work for Eon Dental, and we are being compensated by NDX in order to conduct this webinar. So let's begin with this webinar. So as you guys know, in today's lecture, we're going to be talking about very important practices with clear aligners. We're going to talk about the concept of IPR and its importance and role in success in clear aligner therapy. We're also going to be talking about the importance of synergism, antagonism, and how to apply these concepts when planning for tooth movements. So basically, we just want to help you understand how to utilize the clear aligner force system to work in your favor. Starting with the first segment, we're going to be talking about interproximal reduction. And before we go into the details, I just want to make sure that whenever you think about interproximal reduction, you just need to understand that this is something we use in order to create space. So let's start with defining, or sorry, before going with the definition with IPR, let's talk about what exactly we'll be covering in regards to IPR. We're going to define what IPR is. We're going to cover a few factors regarding the safety of IPR. And then we're going to talk about when it is indicated, when it's contraindicated, and the methods with which we can perform IPR. So starting off with its definition, IPR simply is a procedure in which we remove very small amounts of the proximal surfaces of teeth, and it's usually done through stripping. So a lot of practitioners have major concerns regarding the safety of interproximal reduction, and this is because we are removing parts of tooth structure and its sound tooth structure. So a lot of people have some concerns, or a lot of clinicians and sometimes even patients have some concerns regarding performing this procedure. But it's very important to understand that as long as we are performing interproximal reduction with safe amounts and that we're not overdoing it, we are definitely not going to cause any damage to the patient's tooth structure. So research and studies have actually shown that up to 50% of proximal enamel can be safely removed. So this is basically a chart and an image that shows the thickness of the proximal enamel surfaces from the mesial as well as the distal side. Now, of course, we're not going to know these numbers by heart, but it's just important to understand that whenever we perform IPR, we said that we don't want to exceed 50% of the thickness of the proximal enamel. So for example, if I'm taking a look at the second premolar, the mesial surface is about 1.19 millimeters. So this means I have almost half of the amount of this tooth structure that of this enamel that I can remove without being worried about injuring the patient's tooth structure. So again, this is just to let you know that whenever a clear aligner company plans for a specific amount of IPR, just always take this into consideration. It's important to be cautious, but don't be too hesitant about performing IPR because I'm sure these clear aligner companies do take your patient's safety into consideration. So just rest assured that it is okay to perform IPR as long as you're doing it correctly. Now, just to talk about more studies that discuss the amounts of IPR that can be safely removed. Some studies state that we can remove up to 9.8 millimeters of proximal enamel from 8 posterior contacts. So this would basically mean that per contact, we can obtain 1.225 millimeters. Other studies state that we can remove up to up to 6.4 millimeters from 8 posterior contacts, which would basically mean that we can obtain 0.8 millimeters per contact. And I just want to point out that when we say 0.8 millimeters per contact, we are referring to the proximal enamel surfaces on both adjacent teeth. So, for example, if I'm performing IPR between two premolars, the first premolar and the second premolar, and the contacts between them, this would mean if I'm performing 0.8 millimeters, this would mean that I would perform 0.4 millimeters on one side and then 0.4 millimeters on the other side, or 0.4 millimeters on one tooth and 0.4 from the adjacent tooth. So this is actually distributed between two adjacent teeth, and it should not be removed completely from one tooth, obviously. Other updates or other researches even state that we can remove up to 1 millimeters from contact points in the buccal segment and no more than 0.75 millimeters from lower incisors. So as you guys can see, there's some variety in research in regards to what is considered safe and what is not. Now, most clear aligner companies do not exceed 0.5 millimeters of IPR in contact areas. So again, as I said, as long as you are performing IPR correctly, as long as you're being cautious, it's okay to perform it. And it's very important not to ignore it. Now, it's usually not something that you have to think about because, as I said, clear aligner companies already include them in your treatment plans. But it's important not to ignore them and actually perform the needed amount just to make sure that teeth actually have enough space in order to carry on with the movements that they are planned to have. Now, one thing that is usually recommended for clinicians to follow following the IPR procedure is to apply topical fluoride. And this is simply because we all know the benefits of fluoride. We know that they provide remineralization. They strengthen the enamel tooth structure by forming fluorapatite crystals instead of hydroxyapatites. So we already know that they will strengthen the tooth structure. And sometimes after IPR, some patients may experience some sort of sensitivity. So the application of this topical fluoride will help reduce the sensitivity and maybe even avoid it for some patients. So it's very important to have this step done as well. Now, when we talk about the safety of IPR, it's also very important to mention periodontal health. Again, many clinicians have some concerns regarding the health of the periodontium when they perform IPR. But studies have shown that in the absence of inflammation, increased root proximity following IPR and ortho treatment will not increase the chances of bone loss. On the other hand, if patients already have an existing inflammation, this increased root proximity may actually rapid the progression of periodontal disease. So what we can simply take away from this is if a patient has poor periodontal health, bad oral hygiene even, we shouldn't be performing IPR. But if you think about it, such patients should not be undergoing any kind of elective dental treatment. So they should not be doing ortho treatment. They should not be having any prosthetics being done. So it's just about being attentive to the kinds of patients that we are selecting for treatment and making sure that once we stabilize their condition, once their periodontal status is stable, then we can start thinking of ortho treatment and performing IPR and all of the other procedures that come along. And if we want to talk about caries as well, studies have shown that no increase in the incidence of caries or periodontal disease was found 2 to 5 years following interproximal reduction. So again, as long as the patient already has good oral hygiene, and as long as they do not have any existing inflammations, it is safe to perform IPR. And one of the safety precautions that clinicians are recommended to follow is to always make sure that they have some sort of air and water cooling. And this is basically just to avoid any temperature rises because sometimes this may lead to irreversible damage to the pulp or irritation to the patient. So it's just important to make sure that you are using the water syringe and maybe some air cooling while performing the IPR just to avoid any discomfort to your patients. So as I mentioned, when we talk about IPR, and we're going to be talking about their indications and contraindications in a bit, just keep in mind that you do not have to actively plan for IPR for your patients. You just need to make sure that you check out what is already built in within your treatment setup. So it will be included in your treatment plan with whatever clear aligner provider you're dealing, but it's just important to take a look at the amount of IPR that is planned and ensure that you actually perform it on your patient. So as I mentioned, we're going to talk about the indications. And again, IPR is something you think about whenever you think about needing space. So we already know that clear aligners are a closed system. And when we say a closed system, it simply means that there are certain forces. So with fixed spaces, it's a bit different because when we have forces being applied with clear aligners, it's a closed system. So there's no other place for these forces to be dissipated except within the aligner. So if we have forces for certain movements to take place, and there is no space for these movements to actually happen, what could happen is some unwanted movements. So in order to avoid this kind of unwanted movement, we always need to make sure that we have enough space for these movements to happen. So whenever we think of IPR, or whenever we want to plan IPR as clear aligner providers, we have to figure out where we exactly need space. So some of the indications of IPR include space creation for incisors retraction. So we have already discussed in the last webinar that retraction is one of the movements that actually requires space, and it occupies a space in order to happen. So in a lot of circumstances, we actually need to plan for IPR in order to be able to retract teeth. And other scenarios could include tooth size discrepancies. So for example, if I want to talk about a case where I have spacing between the teeth and I want to retract the upper arch or the upper interior segment, I want to retract it a little bit. So I will reach a point where I would have a limitation to how much I can retract the upper arch. And this is simply because there will be an interference with the lower arch. So in that case, I will have to perform some IPR in the lower arch, simply because there might be some discrepancy between the sizes of the teeth in the upper and the lower arch, or as simply a tooth arch size discrepancy where the teeth are bigger than what the arch can hold, and therefore I need to perform IPR to make sure there's enough space for all of the teeth. And this would take me to the next point, and it's resolving mild to moderate crowding. So in cases where I have mild or moderate crowding, I will need to perform IPR to obtain the amount of space needed to align and level the teeth. However, I do want you to keep in mind that sometimes IPR is not the only way that we obtain space. So for example, if I had a severe crowding case, then in that case, I will need to combine IPR with other types of space provision. So basically, I could combine IPR with expansion, I could combine it with proclination, just in order to be able to get the space that I need. Again, this is not something that you need to plan from your end. This is something that your clear aligner provider usually plans within the treatment setup, but it's important for you to understand why it is being planned within a certain case. Other indications for IPR include space creation in cases of intrusion. So, I'm sorry. Okay. I'm just gonna drink water. I'm very sorry. Okay. So another example would be intrusion. So we know that in general, teeth, I'm just gonna show you guys this figure just for you to be able to visualize things. So in general, an incisor, for example, tends to be wider incisally than it is cervically when we're talking about its mesiodistal width. So think about us wanting to intrude this tooth, for example. If I wanted to intrude it, obviously I'm going to need space. And this is because, again, its incisal edge will occupy more space than its gingival part is. So for that reason, sometimes we need to perform IPR whenever I'm planning for intrusion. IPR can also be used for cosmetic recontouring or for the closure of black triangles. So as we can see in this figure, for example, if we have black triangles here, if I plant some IPR and I strip some of the teeth from the proximal surfaces, I will be able to have better contacts between the teeth, and therefore I will be able to resolve the black triangles. Okay, so now let's talk about the contraindications of IPR. Okay. I'm sorry, just give me a second. Okay, so contraindications of IPR include square-shaped teeth, poor oral hygiene, small teeth, or rotated teeth. When we talk about square-shaped teeth, the main reason that IPR is contraindicated is because the surfaces they're kind of like flat. So if I perform IPR here, I will be removing a very big amount of the tooth structure. And this is because it's a flat surface, so the amount of tooth structure I will be removing will be from the incisal edge up until the gingival part. Whereas triangular shaped teeth, are easier to have IPR planned for or are more recommended for IPR simply because their shape helps in that. Because if I remove tooth structure from this part, which is the incisal part, I will not actually also have to remove from its gingival part, and therefore I will be removing less amount of tooth structure. Now, it's not always contraindicated to perform IPR for square-shaped teeth, but in general, we try to avoid it. Other contraindications could include patients with poor oral hygiene, and we already mentioned that this is because patients with poor oral hygiene could have things get worse after we have IPR performed for them. Okay, just give me a second. I'm just gonna mute myself for a bit because I need to cough. I'm very sorry for the inconvenience. Okay, I'm all good now. So, as we mentioned, patients with poor oral hygiene could have their situation get worse if we perform IPR or basically any kind of elective treatment. And this is simply because they must have their condition stabilized before we provide them with any kind of elective dental treatment. We generally also try to avoid IPR for patients with small teeth. And this is simply because they are already small in size. So imagine having to perform IPR and removing even more of their tooth structure. They could end up being very small in size. So we would never, for example, perform IPR for peg-shaped laterals. Another contraindication could be rotated teeth. Now, we can perform IPR for teeth that are rotated sometimes, but then we would have to plan it as only one-sided IPR. So in that case, you would have the IPR blocked on this tooth and then performed on one tooth. However, we generally try to avoid that, and we would only go for it if we absolutely had to. Otherwise, we can simply delay the IPR until we reach a point where the contact points are properly accessible, and so we can actually perform IPR easily in that contact point. So one of the very important tips when performing IPR is to always pay attention to the timing during which we perform IPR. So we have to make sure that we do some initial leveling and alignment. Again, this is because if I perform IPR at this point, for example, I would be removing some tooth structure from the palatal surface of the central incisor rather than removing it from its proximal surface. So we actually just have to wait until it's properly aligned and the contact point can be properly accessed and easily accessed, and then we can actually perform IPR as needed. So there are different methods through which we can perform IPR. We have manual strips, mechanical strips, diamond discs, safe-tipped burrs, and oscillating segment discs. So what is the best technique? All of these are techniques that you can actually use in performing IPR. And of course, each of them can have some advantages, some disadvantages. For example, manual strips are very widely used. They are generally user-friendly and easy to use. And they are very helpful, especially for post-IPR contouring. However, their problem is that they are very time-consuming, and sometimes it can be difficult to reach posterior contact points while using manual strips. And this is because they are manual strips that we are using or that the clinician is using with their fingers or with their hands. So it can be quite difficult to get that far back into the patient's mouth. So for example, mechanical strips, which are very similar to manual strips, but they're mounted on a handpiece, actually are more efficient and can and need less chair time in comparison to manual strips. And they do provide, or they can actually be reached far back more than what a manual strip can. So mechanical strips can also provide us with good predictable results. They give me smooth surfaces. And in general, they do not pose any risks, and this is because we do not have the risk of cutting into the patient's soft tissues. On the other hand, diamond discs do have that. They do have that possible risk. So in general, with diamond discs, we have to always be very careful when performing IPR, and we usually have to use some kind of safety guard in order to make sure that we are guarding the patient's soft tissues. But of course, that does not change the fact that diamond discs are in fact very efficient. They do produce very smooth surfaces. We also have safe-tipped burrs. Now, safe-tipped burrs are also considered efficient, but they don't provide a lot of flexibility. And it's because it's just like a burr. And in general, they're a little bit aggressive. So we usually use them if we know that the amount of IPR we want to perform is more than 0.3 millimeters. And this is because they remove a lot of enamel. Another thing about safe-tipped burrs is that sometimes they can cause some ledges, so they don't always result in very smooth surfaces. Generally speaking, mechanical oscillating abrasive discs are more efficient. They produce more regular enamel surface and they need shorter chair time in comparison to manual strips, according to research. So one could say that it's actually recommended to use mechanical strips in performing IPR. Studies have also shown that they can produce smoother proximal enamel surfaces in addition to less acid penetration than safe-tipped burrs and than oscillating segment discs. So they do have a clinical advantage in reduced caries susceptibility post-IPR. I'm going to leave you guys with this video that shows the IPR performing procedure.
First step before doing IPR should always be checking the contact points with a floss. After that, create access for the interdental strip by opening the contact using a thin interdental strip. Now we can proceed with performing IPR. Let's say 0.3 IPR is needed for this contact. Start the stripping gradually. Take the 0.1 strip, hold it properly with your fingers, and start sawing between the teeth from the incisal edge towards the gingiva. Check with the 0.1 IPR gauge by sliding it in the contact. Now take the 0.2 strip and do the same process. Check with the 0.2 IPR gauge. Notice how it is being forced in the contact. This means that more stripping is needed. Strip with the same size again, recheck, and ensure the appropriate amount is done. Finally, take the 0.3 strip and follow the same steps as previously done. Let's explore the other available options to perform IPR. The first one is going to be interdental strips mounted on a handpiece. This system is fast, convenient, accurate, and you can adjust it depending on which tooth you are doing IPR to. Second option, diamond discs, are always user-friendly, but it is advised to use it with a guard to prevent any soft tissue injury. And finally, IPR performed using burrs. Place the burr perpendicular on the tooth buccally and start moving from the gingival to the occlusal side until you reach the tooth lingually. The smallest reduction done using a burr is 0.3 to 0.4 millimeters. Be cautious when using it to avoid forming any ledges and also not to injure the soft tissues. When doing IPR, make sure you are performing it in the correct axis to avoid forming any ledges. After doing the IPR, take polishing interdental strips and smoothen the contacts. The final step is to apply fluoride on the teeth to avoid any sensitivity. Here are some tips when performing IPR. Always be careful not to injure the patient by doing proper cheek and tongue retraction. Make sure the contact point is accessible and always check with the floss that the contact is properly open to avoid forming any ledges. When performing IPR to a young patient, be cautious to avoid pulp exposure because of the teeth's large pulp chambers. Be aware of overstripping by always measuring and keeping track of the IPR done. First step.
So by this, we have covered almost all the important points regarding IPR. As mentioned, it is something that is already included within your treatment setup provided by your clear aligner provider. And it's not something that you need to plan, but it's very important to always make sure that you pay attention to the amount of IPR that is included in your treatment setup to ensure that you're actually performing it on your patient's teeth. Now for the next segment, we're going to be talking about synergism and antagonism and planning movements with synergism and antagonism. So we already know that, so we all know Newton's third law, and it is with every action, there is an equal and opposite reaction. So we know that every time we plan for a specific movement, we have an opposing movement that happens as a counteractive force to the movement that we have already planned. And this is basically the main concept that we want to think about or talk about when we are planning for synergistic and antagonistic movements. In general, during staging with clear aligner treatment, it is very important for us to try our best to combine synergistic movements together. It's actually recommended because it simply helps their expression more predictably and efficiently. And the opposite is true for antagonistic movements. We always try to separate these movements and make sure that they are not planned together. Instead, we try to stage and sequence them simply because if we do plan them together, this could lead to loss of track because their expression would be reduced and would not be as predictable. So when we think of synergism and antagonism, we try to think of them on an arch level and on a tooth level. So whenever we as clear aligner providers think of how we want to plan synergistic and antagonistic movements together, we always think about movements that happen on an arch level. How can I combine retraction, for example, of the anterior segment with other movements for it to be expressed more predictably? And I can also think of it on a tooth level. So, for example, if I'm extruding a tooth, what are other movements that I can plan with that tooth being extruded predictably? So this is basically the main concept of how we think of synergism and antagonism when planning movements. So now let's talk about them one by one or little by little. So whenever I want to plan posterior expansion, for example, one of the movements that I can plan along with it in order to have them expressed better would be retraction. And I'm just going to use this aligner that I have here for demonstration. So why is it that we like to combine posterior expansion with anterior retraction? So basically, whenever I expand it's just very important for you guys to imagine how an aligner works, just for you guys to know why we plan these movements together. So when I plan for expansion, this posterior force will result in the anterior segment being retracted. So whenever I'm expanding the aligner, it actually pushes the anterior teeth back. So obviously it would be good if I plan for a movement that is already sort of happening. So I'm expanding and there is already a counteractive force causing the retraction of the anterior segment. So if I plan for it, it would also be expressed even more predictably and more efficiently. And of course, if I do not actually plan them together, I could end up increasing the number of aligners without actually the need for that. So again, it will be more efficient and it will be more cost effective to do it that way. And of course, it will have less treatment duration for our patients. On the other hand, if I'm basically constricting the posterior segment, as you can see, the aligner will be pushing the anterior teeth forward. So again, if I can combine these movements together, since it's already happening, it will definitely be more predictable and more efficient in my treatment setup. However, if I wanted to sort of reverse this combo of movements, it will definitely result in collapse. So basically, if I want to constrict my posterior segment and at the same time retract the anterior one, it will definitely be more difficult to achieve. And this is simply because, again, when I constrict the posterior segment, there will be forces that are causing the proclination of the anterior segment. So having to counteract these forces and have some retraction planned will definitely be very challenging and could lead to loss of track. So this should always be avoided. However, sometimes there could be certain cases where it is absolutely needed to combine these movements. It could be because, for example, we have a limited number of aligners that we can use. It could be because the patient doesn't want to have a very long period of treatment. There could be so many reasons. In that case, we could still combine them, but we will have to lower the rate to the half of the normal rate that we usually use. But of course, we still would have to let the patient know that they must keep in mind that sometimes this could affect the tracking of the case. Again, generally speaking, this is not something that you as practitioners need to think about. This is something that your clear aligner provider must keep in mind while planning for your treatment setups. But again, it's good for you to know so that when you take a look at your treatment setup, you would be able, for example, you would be able to spot the kinds of movements that are synergistic. So if for example, within the plan, there was a movement that's antagonistic, that is there are two movements that are antagonistic but are being planned together, it's important for you to be able to tell that they should not be done together and that they should be sequenced. Um, so another thing, another movement that we can talk about is molar distalization. So basically, if I'm planning for distalization, I'm planning for the movement of the posterior teeth backwards. So naturally, the counteractive force would be a force that pushes the anterior teeth forward. And therefore, it is actually recommended to plan proclination of anterior teeth with the molar distalization. However, it is contraindicated to do the, oh, sorry, I thought it was here. It's actually contraindicated to do the opposite. It's contraindicated to do some sort of incisor retraction along with the distalization. What's actually usually done is some sort of sequencing. So usually clear aligner providers plan the distalization of molars, and they usually do it one tooth after the other. And then they start with retraction of the anterior segment altogether. They don't really retract the anterior segment while the posteriors are being retracted, because there will be loss of anchorage and there will be loss of track and collapse. So it's very important to make sure that these movements are actually being planned together. Sorry, separately and not together. So another example would be when we are planning extrusion or intrusion. So generally speaking, extrusion is already a very challenging movement when we plan it with clear aligners. And we already know that we almost always plan extrusion while using other sorts of auxiliaries, whether we're talking about attachments, whether we're talking about elastics, if we are planning it in the posterior segment. So generally speaking, it's not an easy movement. And the same applies with intrusion. And this is because both of these are vertical movements. And it is generally challenging to perform vertical movements with aligners and with fixed braces in general. So whenever I'm planning some sort of extrusion for the posterior teeth, there will be a counteractive force that is causing the intrusion of the anterior teeth. So again, if I take a look at my aligner and take it as an example, if I press down on it here, you will see that the anterior segment is actually being pushed upwards. So again, there's always some sort of counteractive force that is acting against the force that I am planning. So again, when I extrude, the anterior segment will be intruded. So it's actually recommended to always plan the extrusion of the posterior segment along with the intrusion of the anterior segment. And the opposite is true. So if I'm actually planning the intrusion of the posterior segment, there will be an extrusive counteractive force. So it's also actually recommended to combine these together. Whenever I want to extrude the posterior segment, it is recommended to plan the intrusion of the anterior segment. But imagine wanting to intrude the posterior segment and simultaneously also intrude the anterior segment. This will definitely not happen, simply because, again, I am extruding, so there's a counteractive force that is causing I'm intruding, so there's a counteractive force that is causing the extrusion of the anterior segment. Now, if I also want to intrude it, I will be acting against this force. So what could happen is lack of expression of both movements. If I want to plan both of these antagonistic challenging movements together, I could end up with two movements that are actually not tracking well, and this again could lead to some sort of collapse. So it's very important to be very mindful of these movements that we are planning together. And as I already mentioned, planning for a movement that is already happening as a counteractive movement to the movement that I'm already planning will definitely lead to better expression of both movements. So generally speaking, if I want to talk about movements that are good when combined together on an arch level, I would say that expansion and retraction should be planned together because, again, as I said, whenever I expand the posterior segment, I'm not sure which view is more clear for you guys. So whenever I expand the posterior segment, there will be some sort of retraction as a counteractive force. And whenever I constrict my posterior segment, there will be proclination. So combining these two movements together is definitely more predictable and they will definitely be expressed better than if they were sequenced. And the same thing applies to distalization and proclination. So whenever I plan the movement of teeth distally, it is recommended to plan some sort of proclination for interior teeth. And this is because it will happen as a counteractive force. And posterior extrusion will be more predictable if it was combined with anterior intrusion. Now, of course, the opposite of all of these combinations is definitely not predictable, and they should not be combined together. So for example, I should not plan for expansion and proclination, because I will be acting against a force that is naturally happening. So it is very likely that both of these movements are not going to happen. Or even if they do, they could be expressed to a lesser degree than that I want. We should also avoid combining constriction with retraction, distalization with retraction, and we should definitely avoid planning posterior extrusion with anterior extrusion all at once. So now we're going to talk about synergistic and antagonistic movements on a tooth level. And generally speaking, it is very recommended to combine movements that are challenging with those that are considered to be more predictable. So for example, if I'm talking about rotation of a cone-shaped tooth, such as a premolar or a canine, perhaps even a molar, even though it's not cone-shaped, rotation can sometimes be challenging. So combining rotation with expansion will definitely increase the predictability of the expression of rotation. And this is simply because so if I want to take this glass cup as an example, we already know the problem with cone-shaped teeth in general. So with aligners, basically movement is more predictable if we have more surface area that is wrapped by the aligner. So cone-shaped teeth are a little bit difficult to grab, especially that they are not just standing on their own. They usually also have teeth adjacent to them. So they're generally very difficult to grip by the aligner. So basically, if I want to rotate this tooth, it's definitely going to be challenging. However, imagine that I am expanding and rotating the tooth at the same time. First of all, I will be having more surface area in contact with the aligner because of the expansion. I will simply be trying to move the tooth in a different dimension. So it's just going to be grabbing more of their surface area and therefore increasing the expression. And at the same time, expansion is a movement that provides me with space. And this will reduce friction with adjacent teeth. And we already mentioned that clear aligners are a closed system, and we definitely always need space for movements to track, especially challenging ones like rotations. So expansion will give me that space that I need, and it will make it easier for me to rotate a tooth. So generally speaking, it is recommended to combine expansion along with rotation. Now, another thing regarding rotations. So basically, if I want to plan some sort of distalization for this tooth, it's definitely recommended to combine it with some mesial out rotation. And when I say mesial out or distal out, we're basically referring to, so for example, if I say mesial out, it simply means that the mesial part of the tooth is being pushed out of the arch, whereas distal out means that the distal part of the tooth is being pushed out of the arch. So this is an example where we have performed some sort of mesial out rotation, as you can see. So if I'm distalizing this tooth and planning mesial out rotation, I'm basically moving it in the same direction. However, imagine the opposite. So again, I'm going to use this glass cup as an example. So imagine that I am basically trying to rotate this cup in this direction, but at the same time, I'm trying to move it distally. So I'm basically doing some sort of distal out rotation and trying to move it distally. And I want them to happen at the same time. It's just not possible. This is simply because they would be acting opposite to each other. So one will definitely not happen. So maybe perhaps the rotation won't happen. Instead, I will only have it distalized. Sometimes they will cancel out each other and neither of them will be expressed. So it's very important to know which kinds of movements you can combine and which kinds of movements you cannot combine, just to make sure that your movements are tracking well the way you have them planned. Again, if at any time we had to combine these antagonistic movements, then we simply might have to do them at a much slower rate. And usually what clear aligner companies do is that they generally inform their doctors that this could be a challenging movement and that it could lose track. So it's very important to keep this in mind. Now, another combination of movements that we can talk about is retraction and extrusion. So we already know that when you retract a tooth, like in this example, what we did was simply retraction, or you can think of this as a palatal crown torque or a negative crown torque. So basically, we retroclined this tooth. So this is known as the drawbridge effect, and this is simply because this tooth was not actually extruded. But if you look at it, you will get the illusion that it did get extruded. And this is basically what happens when we retract any tooth. And sometimes, so this is actually known as relative extrusion. So obviously combining retraction with extrusion will definitely lead to better expression of extrusion. And we already said that extrusion is a very challenging movement. So a lot of times in certain cases where a lot of where big amounts of extrusion are required, sometimes we tend to rely on some relative extrusion through retraction in order to have that extrusion happen rather than relying fully on pure extrusion. So obviously the same is true for proclination. So whenever I want to procline the tooth, you can actually think of it as the opposite. So let's say that I proclined this tooth rather than retracted it. Again, you will get the illusion that the crown got shorter, but it actually didn't. It's just an illusion. So again, combining proclination with intrusion they are considered synergistic movements. So you will increase the predictability of both of these movements, and combining them together is definitely recommended. This is just a video that an animation that shows how it happens. So notice how when we proclined the tooth, it looked like the tooth got shorter, but it's actually still like we didn't do any kind of active intrusion or vertical movement on the tooth. It still has the same vertical dimension, but it appeared as if it got intruded simply because we proclined it. And the opposite is true for when we retract the tooth. So just like we summarized everything for the arch level synergistic and antagonistic movements, we can summarize them for tooth level movements. So basically, if we want to talk about movements that are good or more predictable when combined together, we said that expansion and rotation can be performed together, again, simply because this will allow me to engage with a greater surface area of the tooth. And it will also give me more space during rotation, which could lead to better expression of the movement. We can also combine mesial out rotations with distalization because they're basically moving in the same direction. We can also combine distal out rotations with mesialization. We can also combine extrusion and retraction, and we already said that this is because whenever I retract a tooth, I will get some sort of relative extrusion. And the same is true for intrusion and proclination. Whenever I procline a tooth, I will get some sort of relative intrusion. So combining these two together will definitely lead to better expression of both of these movements. Now, again, we also have movements on tooth level that we would not prefer combining. These would include distal out rotations with distalization. And this is simply because, as I said, you would be having two movements that are opposite to each other happening at the same time on the same tooth. So they will definitely cancel out each other. So it's preferable to have them sequenced. So for example, we can plan having the tooth derotated first, and then we can start with its distalization. And the same is true for mesial out rotations with mesialization. So we cannot have a tooth being rotated mesially out and also have it mesialized. Instead, we can simply derotate it first, and then we can start with its mesialization. I know when we say it in words, it's very confusing, and sometimes you might get lost, but just go back to this figure or to a similar figure and you would basically fully understand it. So again, if I want to rotate this tooth and move it distally in these two directions, it will track properly. It's recommended. It's actually going to result in a better rotation because we already know that rotation is a challenging movement, and so is distalization sometimes. It depends on the arch, but that's not our main concern right now. So basically, combining these two together will definitely have them expressed in a better way. Um, And of course, we already said that we should not combine intrusion with retraction. And this is simply because whenever I retract a tooth, I will get relative extrusion. And intrusion is opposite to that movement. So obviously combining them together could lead to loss of track. And extrusion and proclination should also not be moved together. Again, sometimes we might have to, for one reason or another, combine these antagonistic movements. In that case, we must lower down the rate and make sure that we are planning them at rates that are less than what we usually plan. So I'm just going to play this video for you guys. So notice how in the last few steps, we were basically planning intrusion with retraction. So this is definitely not something that is recommended. Ideally, we could have the retraction planned first and then the intrusion, or we could do the opposite. We could have the intrusion planned first and then the retraction, but it's preferable not to have them combined together. Now, if we sequence them, obviously this will increase the number of steps needed, but as long as it's a safer option and as long as it will result in better tracking for the patient, then I truly think it's worth it. Now notice how we are also planning some sort of extrusion on the premolars, and while we are intruding the anterior teeth, this is definitely recommended. These two are synergistic together. And again, we already said this is because whenever I want to, so for example, okay, so this is the upper arch. If I want to extrude my posterior segment, the upper segment will already have some intrusion happen counteractively. So it is recommended to combine these two together. So we're planning the intrusion while the extrusion on the premolars is happening. This is another example. Now, as you can see, we are planning intrusion for both the upper anteriors and the premolars together at the same time. I'm gonna play it again. So again, ideally, these two are movements that should be separated and they should not be performed simultaneously, simply because this could lead to loss of track, this could lead to collapse, and loss of track would mean having to go through a mid-course adjustment with the patient. And even if we had to have a longer treatment from the start, I truly believe that it would be more convenient for the patient than having to have them go through a mid-course adjustment and having to take new scans and starting over with the treatment.